Everyone, ITECH welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is HIV-TB clinical aspects and speaker is Dr. Upasna Agarwal. Dr. Upasna Agarwal is currently working as Head, Department of Internal Medicine at National Institute of Tuberculosis and Respiratory Diseases in New Delhi. She is also the in charge of the ART Center and ICDC Center at NITRD. She is an internal medicine physician specializing in HIV and AIDS. She has expertise in developing research protocols with the special interest in HIV-TB and TB iris research. She is a trainer on TB, HIV-TB, antiretrovirals, and TB diabetes. We welcome you, madam, for today's NDLS session. I would request Dr. Upasna now to take over the session, please.
Good afternoon, everyone, and welcome to this session of NDLS on HIV-TB clinical aspects. In this particular talk, we will be just focusing on the clinical part of HIV-TB. All of you have undergone the new guidelines training already, and so we won't be discussing them much in this talk. We will be talking about what are the clinical picture and what are the clinical aspects of HIV-TB case management. So to begin with, background information, we all know that HIV-associated TB is a serious threat to public health. It is the most common presenting illness among people living with HIV, and it is a major cause of death in people with HIV. This is the latest WHO report, the 2016 WHO TB report, which shows that there are about 1.1 million new cases of TB among HIV positive people. And out of these 1.1 million, there are about 4 lakh people, that is out of 11 lakh, about 4 lakh people with HIV-TB die. So you can see, even if it is only 11% of the TB cases, the amount of people who have HIV and TB who die is nearly 1/3. If we look at the Indian fact file, as per the latest RNTCP status report, the HIV prevalence among new TB cases is around 5%. This is a national average. It will of course vary from region to region depending upon the region's inherent HIV prevalence and the TB prevalence. And nearly 110,000 HIV-TB patients are emerging annually. So if we look at the globe, we have the second highest burden of HIV-TB. That means that 10% of the global burden of HIV-TB is present in India. And once again, the mortality is high. Nearly 1/3 people who get HIV-TB in India also die or succumb to TB. This is a slide which I took from the old guidelines, the NACO OI guidelines 2007. And we can see from the data from our own ART centers that 65% of the people who come to our ART centers have TB at some time or the other. And in those guidelines, it was written that HIV-TB co-infection would be one of the most challenging issues in the effort to scale up ART program. Now, if we look at the what happens at the pathogenesis level, there is a bidirectional interaction between HIV-TB, and there is evidence of each disease worsening the other. So what happens in an HIV-TB case? HIV is the known strongest risk factor that we know for development of TB. And why is it so? Because the target of HIV is a CD4 cell. And CD4 helper cell, the T helper cell, is actually the type of cell which will orchestra the cell-mediated immunity, the type of immunity that we need against Mycobacterium tuberculosis. So when you have an infection in your body, which affects that arm of your immunity, which is responsible for preventing tuberculosis or controlling and containing tuberculosis, it is understandable that there will be more tuberculosis in HIV positive cases. So what happens? You don't have cell-mediated immunity. So your risk of progression from latent to active TB in HIV positive is high. You have a higher risk of getting new and recurrent TB infections. If you get TB, then the disease is more disseminated and atypical because you do not have the immunity to contain it. And once you get the TB, you get serious forms, you get disseminated atypical forms. It becomes a major cause of mortality in HIV positive cases. Similarly, on the HIV side, if you look at what TB does to HIV, we know that TB causes something known as systemic immune activation in the body, TB per se, TB on its own. And what is systemic immune activation? It is nothing but increased secretion of pro-inflammatory cytokines. So if you have TB on the background of HIV, then the systemic immune activation, which is caused by which is caused by TB-induced immune activation, will cause increase in the HIV viral load. And so the sum total would be that you have HIV and TB and it has become a deadly cocktail. But if you administer ART and ATT, it will reduce the case fatality rates and the incidence of TB and recurrence of TB. So now with this background information, coming to the co-management of HIV-TB. See, when we talk of management of HIV and TB, the case management, it is actually management of two different diseases. It is management of active TB disease and it is management of HIV disease. Now we have to see how to go about it. When we come to management of a case with dual disease, there are certain issues in co-management of HIV and TB which are unique to this set of patients. One is getting disseminated and serious forms of TB presentation in an HIV case. Secondly is how to make the ATT and the ART compatible, because there are certain issues of drug interactions and overlapping drug toxicities. Third is, it is easy to understand the pill burden would be higher. If you have only HIV and if you have only TB and if you have both, it is very logical that you will obviously be taking more drugs than you would if you had only one. There is a demanding adherence to dual therapy, and there is something known as immune restoration disease or immune reconstitution inflammatory syndrome, which is something that is unique to HIV-TB and can be a problematic issue when you do HIV-TB case management. So coming to the first part. The first part is management of active TB. So in management of active TB, there would be two components. There would be clinical presentation of TB and the other would be treatment of TB, the anti-tubercular therapy. So coming to the clinical presentation of TB. Clinical presentation of HIV-associated TB varies with the degree of immune suppression. Though it is interesting to understand that symptoms will be similar in HIV negative as they are in HIV positive. They would be the same ones like cough, fever, weight loss, night sweats. But the clinical presentation by form of physical findings, they might be a bit dissimilar and they would depend upon the stage of HIV in which the patient is at the time when he acquires TB. If it is early HIV, then the presentation, the X-rays and the physical findings would be similar to as that is seen in HIV negative. There will be more frequent pulmonary TB. The X-ray will show upper lobe infiltrates, cavitations, and sputum smear will be frequently positive. While on the other hand, if you have immune suppression, if you are in late HIV, the CD4 count is less, then TB becomes serious and disseminated. More extrapulmonary sites will be involved and there can be multiple site involvement. The common forms of extrapulmonary TB seen in HIV at low CD4 counts are lymphadenitis, pleural effusion, meningitis, miliary disease, pericarditis, to name a few. Also, when pulmonary TB is there with people with low CD4 count, there is expected to be less pulmonary cavitation and more reticular or reticulonodular shadows, more intrathoracic lymph nodes, atypical involvement of the lower limb, sputal negativity might be more as in HIV negative, and MON2 test might be negative. In late HIV, the overall risk of TB is higher, but it is quite difficult to distinguish it from other serious chest diseases and other opportunistic infections. And at times it might get more difficult to diagnose. So these are some X-rays of our patients from NITRD that I want to share with you. These are X-rays of HIV-TB patients. There is nothing new about these patients. I'm very sure all of you have seen similar X-rays in your clinical practice. The only idea to show these X-rays to you is to show the extensive disease that is available. If you look at the X-ray on the right, can you see how the entire upper lobe has been eaten away with the TB? Coming to the one on the left, can you see the extensive involvement? It is bilateral involvement. There was an empyema also for which a tube was put. Look at this X-ray which is on the right. This X-ray shows extensive lower lobe involvement. This was again a case of a smear positive TB who had lower lobe involvement. Then the X-ray on the left shows multiple site involvement in the same X-ray. There is TB on the right upper lobe. Then there is in the middle lobe and middle lobe of the left side, as well as there is a significant mediastinal and hilar lymphadenopathy. Now this is a CT chest. In CT chest, if you will see where the arrow is, I think you can see that it is showing multiple lymph nodes, and this particular, the film, the picture that you can see on the right side at the top, this arrow is actually pointing towards this arrow is pointing towards this one, a enlarged intrathoracic lymph node with central caseation, which is a very typical finding in TB cases. This is another extra that I'm sharing with you. This case had miliary tuberculosis, plus he had micro abscesses in the liver and the spleen, and he had a cerebral tuberculoma. So with this information, we would like to move on to anti-tubercular therapy. Interestingly, despite the disseminated and atypical versions of TB presentation in people with HIV and TB with advanced immune suppression, interestingly and fortunately, the anti-tubercular therapy remains the same. The anti-tubercular therapy is same as in non-HIV. It is the standard rifampicin-based short-course anti-tubercular therapy that is to be given for HIV-TB cases, and daily ATT regimens are recommended and are now available under the program. All of you have been trained in the new ATT guidelines for HIV cases, and so we will not discuss the programmatic aspects. It is sufficient to say that now daily ATT regimens are available under the national program, and directly observed treatment or supervised treatment is even more important in HIV. One has to understand that in HIV person who has TB, there might not be second chances. So please do not compromise directly observe treatment for anything. An HIV-TB patient, you cannot say that, okay, this time let me give him unsupervised. If he defaults, I will give him another, then I will give him directly observed treatment. Please never consider such an option for HIV-TB patients. Always give them directly observed treatment, because this HIV positive patient might not have a second chance. And no self-administration and non-rifampicin based regimens, because it has been proven time and again that these things cause higher case fatality rates in HIV-TB cases. So what is the standard anti-tubercular therapy? It is the same for all new cases. Or a new TB case is somebody who has either never taken anti-tubercular therapy or has taken it for less than 1 month in the past. You give him the treatment regimen 1. And sorry, there's a typo here. In this, you give 2-RHZD. That means rifampicin, INH, pyrazinamide, and ethambutol for 2 months. And then for 4 months, you give rifampicin, INH, and ethambutol. I'm sorry, the ethambutol has got missed out here. And in previously treated cases, that is people who have taken anti-tubercular therapy for more than 1 month in the past, it will be treatment regimen 2, which is 2 months of streptomycin, rifampicin, INH, pyrazinamide, and ethambutol. Then you stop streptomycin after 2 months, 1 month of RHZE, and then you stop Z, and then you give 4 months of RHE. As I say once again, the DOT strategy, the directly observed strategy, is what is recommended and what is to be used for all HIV-TB cases. No self-supervised or self-administered treatment. And 99 dots we know is a new information communication technology method in which the patient is taught how to give missed calls to a centralized number so that his adherence is recorded. And it is proving to be a very good system of providing supervised therapy for HIV-TB patients on daily ATT. So till now we have discussed that there is no difference in the anti-tubercular therapy for patients who are also co-infected with HIV, but there is only one circumstance in which the anti-tubercular therapy differs from that to what we give in a HIV negative person, and that is a HIV positive person who is on a PI based or protease inhibitor based second line ART. So if the patient is on second line PI based ART, then we have to give a rifamycin, but we cannot give rifampicin, the reason for which I will explain over the next few slides. And rifampicin needs to be replaced with rifabutine, another rifamycin by the name of rifabutine, and we have to give it in the reduced dose of 150 milligram every day. So this was a treatment that we are giving under the National AIDS and National RNTCP control program, but it is hearty to know that the WHO recommendation is also the same, that we should give daily DB treatment for patients of HIV-TB at least during the intensive phase. If for some reason you cannot give it under the continuation phase, then at least during the intensive phase. But India is luckier. We are providing daily ATT now in both the phases, intensive and continuation phase. And WHO recommends that TB patients with HIV should receive at least the same duration of TB as HIV negative. And there is no clear-cut recommendation on whether the duration should be increased in HIV positive cases. And as of now, the same duration is recommended for HIV positive as for HIV negative. So this was about treatment, presentation and treatment of TB in a HIV positive case. Now, how do you manage HIV disease in such a patient? To manage HIV disease, it again has three components. One is antiretroviral therapy, when to give in a TB case, what antiretroviral therapy to give in a TB case, and how to give antiretroviral therapy in a TB case. Second is what is the adjunctive therapy to be given, and how do we manage paradoxical reactions that we see in HIV-TB cases. Coming to the first part, what antiretroviral therapy in HIV-TB cases, and what and why? See, HIV patients with active TB, we all know they have a significantly lower CD4 count than HIV patients without TB. Anybody who sits in the ART center knows this fact that patients of HIV-TB have a much lower CD4 count than the ones who come without TB. And it is interesting to know that even with the same CD4, if somebody at the same CD4, an HIV patient has TB while a HIV patient who doesn't have TB but they have the same CD4, HIV-TB patients are at a greater risk of AIDS and death. The CD4 counts measured during active TB are the actual levels of immune suppression. Please do not think that after TB treatment is completed without giving ART, maybe the CD4 count will improve significantly. There is no such thing. Whatever you are seeing now is the CD4 count that you have to take for deciding management. It is important to understand that TB therapy alone does not significantly increase the CD4 cell count, nor does it significantly decrease the HIV viral load. The use of HAART leads to a reduction in the HIV viral load and causes immunological reconstitution. So co-administration of ART and ATT will reduce case fatality, incidence of TB and recurrence of TB. And this benefit is seen across different ranges of CD4 counts. So what I have just talked about, the utility of ART in HIV-TB is not for any particular CD4 band. The benefit of ART when added to ATT is seen right from low to high CD4 counts, and it is seen uniformly in all HIV cases. So now comes to the question, what ART do we given in HIV-TB cases, and what are the special considerations of dual therapy? So what are the complicating issues? NACO and RNTCP recommendation in this is, as well as the WHO recommendation, that any HIV patient with active TB is eligible for ART irrespective of CD4 count, meaning that any HIV patient who walks into your ART center has active TB. If he is not yet on ART, please start ART as soon as possible. There is nothing known as a TB patient not being eligible for ART. So all HIV cases with TB are eligible for ART. Now we have to see what ART to give. So that will depend upon two things. One are the drug interactions between the two regimens, and the second is the augmentation of side effects that we might see because of overlapping side effects. So coming to the first point, what are drug interactions? Drug interactions are basically when you give two drugs together, then what does one drug do to the other by virtue of the presence of the first drug. Now, why is drug interactions important? Drug interactions are important because they affect the efficacy of any regimen. They are responsible for making your treatment efficacious. Now in ATT, ART drugs are okay, but in ATT there is a drug called rifampicin. Now rifampicin is a potent CYP inducer. What is CYP? It is a system of liver enzymes. Now these liver enzymes which rifampicin induces are actually the liver enzymes which are responsible for metabolizing most of the antiretroviral drugs, that is the non-nucleoside reverse transcriptase inhibitors and the protease inhibitors. So what happens? You have a ART, you put ATT on it, which contains rifampicin. We have already seen that rifampicin cannot be sacrificed. Rifampicin is too important a drug. It is a drug which is rifampicin is a drug which is a sterilizing TB drug, and without it, the case fatality has been shown to be high. So rifampicin rifampicin is to be kept, but if you give it on a background of ART, what happens? The ART drugs, that is the NNRTIs and the PIs, will be totally washed out of the system because of increased metabolism. So what you will get suboptimal concentrations of antiretroviral therapy and decreased therapeutic effects or even development of resistance. Now looking at overlapping side effects. What is the importance of overlapping side effects? See, side effects are important for judging the safety of your regimen. If you want to give A regimen plus you want to give B regimen and somehow the B regimen increases the side effects by its presence, then the regimen might no longer be safe, or you might have to choose drugs which are safe. So the safety of the regimen are actually determined by the adverse events or the side effects, and the main side effects which can be seen in both kinds of regimens are GI intolerance, that is nausea, vomiting, hepatotoxicity, peripheral neuropathy, rashes, and to this I would also like to add nephrotoxicity. So these are some side effects that can be seen either with ATT or with ART, and when given together they can make 2 and 2 5. So then both these points, the drug interaction and overlapping side effects, re-emphasize the point that we have to choose our ART regimen with care when given with ATT. So what ART regimen do we choose? As you must have seen in both the cases, the NNRTI, we want to give 2 NRTIs and 1 NNRTI. So NRTIs are okay. NRTIs have no drug interaction or no major side effect profile with ATT. But NNRTIs have, and out of the NNRTIs, the one that can be safely given with ATT is efavirenz. Because the levels of efavirenz, even at 600 milligram per day, are not significantly reduced by rifampicin, and innumerable studies have shown that it can be safely used in the presence of rifampicin with no reduction in the dose of efavirenz. So under the national program, what do we give? We give either tenofovir, zidovudine, or abacavir with 3-TC, that is lamivudine, with efavirenz when we want to give anti-tubercular therapy. And on the other hand, if we want to give a second-line ART regimen, then in a second-line ART regimen, as I just told you, we cannot use rifampicin because by the effect of rifampicin, the boosted is left in the body to act for HIV. So in these cases, these are the only cases where we would use a boosted PI, boosted in the normal dose, but along with a different rifamycin, which is rifabutine, because rifabutine is a much lesser potent CYP inhibitor, and when given with protease inhibitors, it doesn't cause significant lowering in their levels. So now with this, now we have come to 2 points that yes, we have to give ATT to all our cases. Secondly, what regimen to give, that too we have decided. Now comes the point that when we are looking at 2 things, when we are looking at TB disease and HIV disease, which drug to give first. So please understand that always give anti-tubercular therapy first. The central principle in all guidelines is that the first priority is to start TB treatment. The TB treatment should not be compromised for anything. Like there is a reason why this is important, because we have to look at what is the goal of TB treatment. See, the goal of TB treatment is to bring down the mycobacterial load of the patient and to save life by immediately bringing down the infective load, the mycobacterial load. While what is the goal of ART? The goal of ART is, yes, to bring down viral load, but the actual goal is immune reconstitution. And immune reconstitution takes time. However, before you can even initiate, even as immune reconstitution starts, anti-tubercular therapy, if not given, the patient might possibly die of TB. So we have to remember that a patient has to receive TB treatment first. It should not be compromised. TB treatment will start acting immediately. It will bring down the mycobacterial load. I'm very sure everybody working in ART and in TB must have seen that the patient rapidly starts improving with TB within the first week or 2 weeks max. The patient shows very good response to ATT. Then we have to also give ART, that we have decided that ART is essential because we want immune reconstitution for our HIV-TB patients. And we know that immune reconstitution takes time, 3 months, 6 months, or maybe even a year. So we know that we have to give ART. But if we have to give ART and our ATT is settled, we have to give it as soon as possible. That is between 2 weeks and 2 months. Please remember, ART is essential and it is something that will take time to bring about its effect. And because it will take time to bring about its effect, while also being essential, it has to be started as soon as possible, but with the bottom line that TB treatment should not be compromised. So with this about the treatment and how to give ART in a TB patient, we come to adjunctive therapy. What is adjunctive therapy? It is CPT, co-trimoxazole preventive therapy. What is co-trimoxazole preventive therapy? It is nothing but a single tablet of Ceftriaxone DS, a double dose co-trimoxazole, to be given all HIV positive TB cases, to be initiated as soon as possible and throughout the anti-TB treatment. Its exact mode of activity is not clear. However, it has been shown to substantially reduce mortality in HIV-TB cases, probably because it also prevents a range of other bacterial infections in HIV cases. And now coming to the final part, how do you manage paradoxical reactions? Here I would stop for a moment and talk about what are paradoxical reactions. Paradoxical reactions are actually how do they present clinically? There is a patient of HIV and TB. You started anti-tubercular therapy for him. He started doing well. 2 weeks later, you added HIV therapy. He responded well to HIV therapy. He did not have side effects. He was doing fine. But a week or so later, there is a sudden deterioration in his clinical condition. Now, this deterioration could be anything. It could be a increased lymphadenopathy in the existing lymphadenopathy, a new lymphadenopathy, a worsening pulmonary infiltrate, some new effusion, maybe an expanding CNS lesion, or patient develops TBM. So why does this happen? This happens because of a clinical entity which is called immune reconstitution inflammatory syndrome, TB associated iris. Now this is a syndrome which occurs in about 7 to 40% of cases due to a immune pathology. The immune pathology that takes place in some HIV-TB patients is that when you start ART, the initial 3 months, you have redistribution of CD4 rather than creation of new CD4. So what is redistribution? Redistribution basically means that from the lymph nodes of the patient, there is a release of memory CD4 cells into the bloodstream. Now these memory CD4 cells already had a memory for TB infection because this is a TB case. So they were already primed with TB. And when they come into the bloodstream, they suddenly come into the bloodstream because of ART. They start having increased inflammatory responses due to the presence of these memory CD4 T cells. So it is not seen in everyone. It just happens in a subgroup of people, and it occurs within days and weeks of starting ART, but it is expected to be within the first 3 months of starting ART. Now it poses a diagnostic dilemma. If your patient is not improving, you would obviously think, is the patient a failure of ATT? Is he MDR-TB? Is he XDR-TB? Is the patient having drug toxicities? Or has the patient developed a new opportunistic infection? So it might be a problem for the HIV physician to understand what is happening. And interestingly, there aren't even any diagnostic tests to diagnose TB-RS as of now. They are only clinical case definitions. And these clinical case definitions are given by INSHE. If you will look at the bottom of the slide, there is a reference which is there, which I would like all the HIV people to note. There is a reference. Please go and look up this reference, which gives very clear case definitions of how to diagnose TB-IRS in HIV cases. And there are two kinds of TB-IRS. One is paradoxical TB-IRS, the more common version, in which you see there is an already known case of TB. He also is HIV. He is on ATT. You start ART and then he deteriorates within the first 3 months. The other one is there is a case of HIV. You have screened and ruled out TB. There is no evidence of clinical TB. You start ART and within the first month of ART, he develops TB at some new place. So these are two kinds, but the more common one is the paradoxical iris. And what are you supposed to do in this case? It's very easy to manage. Usually most of the cases are easy to manage because they're mild to moderate and they resolve without any intervention. All you need to do is give some symptomatic treatment, maybe some paracetamol for fever, for if there is a effusion with chest pain, give some NSAIDs. And you do not need to change the therapy. You continue ART and ATT as before. But then one has to understand that there can be some serious TB iris presentations also, like tracheal compression, meningeal disease, respiratory difficulty, massive adenopathy. And in these cases, you might have to add steroids about 1 to 2 milligram per kg for 2 to 6 weeks. And rarely, if you feel that the immune reconstitution is so serious, that the immune pathology has become so serious, rarely, in very rare circumstances like maybe meningitis, you might even have to temporarily stop ART. So these are some x-rays of my iris patients that I'm sharing with you. If you will see the x-ray on the left, this was a patient who had, I'll just pull up a arrow. So this patient had TB and this was the only lesion left when he came to us in the ART center. He was already on ATT for 3 weeks when he came to us and we started him on ART. The patient tolerated ART very well, but he came back to us 6 weeks later saying that he's having shortness of breath. And can you see the extensive kind of lesions that the patient has developed? This is another case. She was a girl who had cervical lymph node adenopathy, which was AFB positive. We also got an ultrasound done for her. In an ultrasound, there was just some minimal ascites, but otherwise it was normal. After starting ART, 2 weeks later, she came back to us with a distended abdomen, with difficulty in passing stool, only able to pass Praetus. And when we examined her, there were signs of subacute intestinal obstruction, and we repeated our ultrasound. And can you see the ascites, how huge the ascites has become for the same patient? Plus their fibrous strands. Then an SOL emerged in the spleen, and there was development of retroperitoneal lymph nodes. So these are the kind of presentations that you can see with TB iris, and one really has to know about this clinical entity. Otherwise, a HIV physician or even a TB physician might feel very confused as to what is happening. So please always remember TB iris when you're managing HIV-TB. The mortality of HIV-TB is high. We have already discussed that even now globally and in India, more than 1/3 of people who have HIV-TB are dying. But yes, it has definitely come down from the pre-ART era when Africa was reporting mortality to the tune of 60%. And it's important to understand that nearly 2/3 of deaths in HIV-TB occur very early, within few weeks of starting treatment. So there is no other condition in which early treatment can be more emphasized. HIV and MDR-TB, there is recent evidence from NIRT Chennai which shows that there is an association between MDR-TB and HIV, and that HIV patients become more rifampicin resistant if they are INH resistant to start with. However, if there is a patient of MDR-TB and HIV, you can safely co-administer the usual CAT4 ATT, that is the MDR-TB ATT, and in cases of MDR-TB, nevirapine might be a good choice in the ART because there is no rifampicin in the ATT, number one. Number two, efavirenz might have some CNS side effects which overlap with cycloserine, a drug used in second-line ATT. So if some patient is developing CNS side effects, then you can consider shifting patient to a nevirapine-based regimen. And case fatality rates are reported to be high in patients with HIV, MDR, TB. So to summarize, TB is a major source of morbidity and mortality in HIV. People living with HIV need early diagnosis and treatment of TB, and the standard anti-TB treatment is seen to be as effective as it is seen for HIV negative. ART needs to be given concomitantly for effective reduction of case fatality. There are some complicating issues when there is clinical management of dual disease. One is disseminated presentation of TB. We have to somehow make the two regimens compatible. There is always a possibility of paradoxical reactions, and there is the issue of high pill burden and adherence. The two regimens are to be given concomitantly but with spacing, and further scale up of ART services and HIV-TB collaborative activities are required and are in process. So So thank you very much for your patience, and I would be happy to take your questions now. I have got some questions already with me that have been handed to me by the ITECH IT people. One is from Rajkot ART Center. It says, is ethambutol recommended in TB meningitis? To this, I would like to respond that for TB meningitis, if you have a patient of TB meningitis and the patient has to receive treatment regimen 1, that is the 6 months regimen or 9 months regimen, the category 1 treatment, then in those cases we replace ethambutol with streptomycin because the penetration of streptomycin is good. However, if the patient is already on, if the patient is to receive category 2 treatment which has both streptomycin and ethambutol, then there is no recommendation to delete ethambutol from it. You are expected to give all the 5 drugs. Now, coming to the second question, I think it's a program question. Some strips, okay, toll-free number is not functioning. How to consider adherence and who should assess this? I think this is a program question and somebody will have, from the 99 dots, would have to answer this. And I will tell the ITECH people to send your question to the relevant person. This is from ART Center Yadgir. Thank you for raising this issue. This is from ART Center Harjot Khosa. Sorry, it is from Alliance. I'm very sorry. It is from Alliance India. Okay, so is there any gap after initiating ART and ATT, or both can be started together? As I said, ma'am, you should actually start ATT first, let the patient adjust to ATT, and then start ART as soon as possible. That is after a duration of 2 weeks, so that the patient has properly adjusted to ART. His vomiting or any small side effects with ATT have actually settled, and he is now in a comfortable position. His ATT has started working and he is in a comfortable position to start his ART. ART CV Raman, suppose a patient is already on ART regimen, then what is the protocol to switch over for daily regimen? This is a problem that is happening for some time, till a time we are not getting the daily ATT for the remaining population, the HIV negative population, but it is a very good point. See, in this I would recommend that if you have already started, or the patient is already on alternate day regimen and he has taken treatment for more than 1 month, then it is best to continue on the regimen that he already has. There is no point of shifting in between and restarting the restarting the ATT from day 1 with a daily regimen. However, what you can do, if you are very concerned, you can actually reinvestigate the patient, and if you feel that the patient is not responding, then maybe you can take a call to restart the entire ATT with a daily regimen. There is a question which says TB therapy alone decreases viral load. This is from Dr. Rewari. For this, I would not know exactly how it alone can decrease viral load, but yes, TB therapy alone is known to increase CD4. But exactly what is the mechanism for reducing viral load, I'm sorry, I will not be able to answer that now, but I can get back to you after doing some review of literature. Okay, Rakesh from L&T ART Center, HART means highly active antiretroviral therapy. HART and ART are interchangeable terms, and it is just a personal preference. Some people call it HART and some people call it ART. So ARTC Yadgir, if patient is on third line ART, then what ATT regimen would be given? See, ARTC Yadgir, if the patient is on third line ART regimen, it has raltegravir and it has a boosted PI, daltenovir with ritonavir. Again, you will have to use a rifabutin based anti-tubercular therapy. From Surat ART Center, how long do we need to prescribe streptomycin in case of TBM Cat1? Streptomycin will be given for 2 months. Streptomycin is always given for 2 months if you are using it in Cat1 for TBM. A very good question. It is always given for 2 months. After 60 injections, you have to stop streptomycin irrespective of the regimen Cat1 or Cat2, whichever you are using. What is the there is Rajkot ART Center says, what is the reason not to extend intensive phase after 2 months if sputum is positive in daily regime? Okay, this is a very interesting question. Rajkot ART Center, the reason for not extending intensive phase after 2 months, if the sputum is positive, now with the gene expert availability, the CVNAT availability, what you are supposed to do is you have to send that patient immediately for CVNAT. Now, if this person is positive and he is RIF resistant by CBNAT. CBNAT results are expected to be available in 1 day. So if he is RIF resistant, there is no point of extending IP. Please immediately send him. Yeah, sorry for the interruption. So there is a very important question. I'm very, very sorry I missed this point in the talk. It was when CD4 is below 50, should we start ART and ATT together? Yes, we have to start ATT and ATT together. It practically means together. It could be same day or maybe with a gap of 1 day. And actually the issue while we are doing that, the principles of treatment do not change. The principle of treatment is still that ATT should not be compromised. But when we are talking of people with CD4 less than 50, the chances of dying are so high that it is said that maybe they, and as I just showed you, that most of the mortality is the highest within the first few weeks of patient presenting to the ART center, and that mortality has been seen to be the highest in patients with CD4 less than 50. So it is seen that there might be a group of patients, like these are the group of patients in which maybe we cannot even wait for 2 weeks. We would want to, but we cannot, because time is running out for these patients and the chances of dying are very high. So in these cases, yes, you have to start ATT and ART together. There is a question which says, what about liver function test in MDR-TB HIV? I am not sure I understand this question, but when we start patients on MDR-TB, whether HIV or without HIV, we do an entire screening for liver function test, and liver function, kidney function, CBC, TSH. There is a huge list of screening that is done, and intermittently patients on MDR-TB and HIV are monitored according to their, it's a symptom-based monitoring, and at that time you can do monitoring for either hearing loss or for liver dysfunction or for kidney dysfunction, as may be the case. Actually, in MDR-TB, it is not the liver which is the bigger problem, MDR-TB regimens. It is the kidney which is a bigger problem. If you look at the drugs which are given in category 4, very few, or there is a very less chance of getting a liver dysfunction, bigger chances of getting a kidney dysfunction. Okay, I'm looking at more questions. Assam, can ascites be cured in HIV patients on ATT? Yes, if it is tubercular, it can definitely be cured. There is a recent paper on HIV-TB cases from India. I think it's not very recent, by R. Jain, Dr. R. Jain, which shows that in HIV positive patients, they gave ATT and it rapidly cleared. The ascites rapidly cleared. Okay, shortage of drugs, ATT and ARV, you will have to ask the program people. Yes, I think I have taken this issue of 50. What things to be considered when turning intermittent dots to daily dots? Well, when you go from daily dots to intermittent dots to daily dots, please see the duration. Can you restart the patient on a daily dots if he has taken treatment for less than 1 month? And then you will have to do all that registration for that patient as you do for every daily dots. You'll have to do the 99 dots registration. You will have to do, you'll have to make that, you'll have to make a box for that patient. You'll have to make a card, an I-card for the patient. Rifabutin usual dose is 300 milligram. I totally agree, but when you give it with a protease inhibitor, it has to be given 150 milligram daily, because the in the presence of a boosted protease inhibitor, the excretion of rifabutin is affected, because of which 300 milligram dose is higher than what would be required for therapeutic levels, increasing the side effects. So with a boosted PI, rifabutin is always given 150 milligram once a day. Now coming to what is the CAT1 regimen for pregnant women with TB meningitis? Very interesting question. For pregnant women, we cannot give streptomycin, and for TB meningitis, we want to give streptomycin. So in such cases, for the pregnant women, we will not be giving streptomycin. We'll give them ethambutol. There is no recommendation to add any drug from the second line into the first line regimen. You cannot start thinking of adding levofloxacin or ciprofloxacin. There is no recommendation for doing that. So such a patient, a pregnant lady, will be on RHZE. from skin reactions occurred after few days, what to do, when to restart. I don't understand which question. Is it for Septron or is it for ATT? Well, if ATT you get skin reactions after a few days, that is before you start ATT, before you start ART, I think then you will have to stop it and do as like you manage all skin reactions, in which case you first try to manage the patient with anti-allergics. You first give a trial of anti-allergics and continue the drugs. If even in the presence of anti-allergics you cannot continue the drug, the allergic reactions do not go or they increase, then you have to see whether they are in the mucosa or in the oral or in any other, in the eye or in the mouth. If they are such, then you have to stop it immediately because it is Stevens-Johnson syndrome. However, if they are increasing but they have not reached the rate of Stevens-Johnson syndrome, all you have to do is stop and reintroduce drugs one by one. The usual culprit for rashes in the ATT is INH, but any of them can cause drugs. Any of the drugs can cause rashes. And I would request that for such side effects, it would be best if you refer the patient to a TB specialist or to a medicine department of your hospital. If CB-NAT does not show rifampicin resistance for somebody who is sputum positive at the end of 2 months of category 1, then you are not supposed to extend IP or to switch regimens. You are supposed to continue category 1 ATT and do the sputum again at the end of treatment. I think that covers most of the questions. Okay, so there is somebody who's asking, patient is on ATT and now it's 2 months completed. Also, she has not adjusted. When can we start ART? See, once again, we have to look at the CD4 count. Ideally, if it is less than 50, then it should have started. And ideally, till now, for all HIV positive patients, we should have in any case started. But if the patient cannot tolerate one regimen, we cannot expect him to be able to tolerate both the regimens. So here we have a case who is on ATT, not tolerating ATT for the first, even after 2 months. The question of starting ART for such a patient doesn't arise because you cannot give only ART. It cannot be that you can give ART and then let us see does he adjust to ART. It is not as if the presence of ART will make the side effects of ATT less. So you have to try harder to make this patient adjust to ATT, and only once he has adjusted will you give him ART, or the patient can actually get very serious side effects like liver dysfunction or maybe kidney dysfunction with dual therapy and succumb to them. If patient has taken both CAT1 and CAT2 and still patient has axillary lymphadenopathy, what to do? Well, in such a case, I would request you to take an FNAC and send it for CB-NAT and see whether it is showing any MTB, active MTB or not. Or the better thing to do, because the patient has already received both category 1 and category 2, and in lymph node you can never be sure whether it is a dead bacilli which has got left over or whether it is an actively multiplying bacilli. You should send this sample to the nearest liquid culture lab. In your area, if you will talk to your DTO, there will be a state reference laboratory which does MGIT liquid culture for TB samples. So I would request you to take a FNAC and send that FNAC for a liquid culture and to see whether it is an active bacteria or whether these are dead bacteria which are lying trapped within the lymph node. Can we extend CP for TB spine, and how many months can we extend? Yes, the program and all guidelines allow for extension of continuation phase in HIV positive cases depending upon the response, and also if the patient has spinal or meningeal tuberculosis, in which case you can increase the CP by 2 to 3 months to make it an entire duration of treatment of 9 to 10 months. Do we have more questions? I think we are done with the questions. I think we are done. Thank you so much. Thank you very much for your kind patience. Thank you.
Thank you, ma'am, for such a comprehensive session. Thanks to all the participants for patient listening. All the participants are requested to kindly enter the e-poll which is going to display on the screen shortly. Thank you all.